Are you ready to explore exciting careers in neuroscience and neurotechnologies? Then join me, your podcast host, Dr. Milena Krastenskaya, or simply Dr. K, and my amazing guests on the Neurocareers Doing the Impossible podcast. Discover what it takes to turn the impossible into reality. Tune in now to a thrilling episode number 86. Welcome to the Neurocareers podcast, where we explore the dynamic intersection of neuroscience, healthcare, and careers. Today, we have the privilege of introducing you to a distinguished guest who is making significant strides in the world of neurosurgery and healthcare leadership. Meet Dr. Atta Ul Aleem Bhatti, a renowned consultant, neurospine and endovascular neurosurgeon, and the founding chairman and CEO of Neurohealth Care for LMIC, based in Geneva, Switzerland. And Dr. Bhatti brings a wealth of experience and wisdom to our podcast with a commitment to self evaluation and continuous improvement. He is dedicated to enhancing surgical clinical outcomes, ensuring that they surpass the natural history of diseases. His impressive career has spanned the globe, and he understands the unique challenges faced by healthcare professionals, particularly in low and middle income countries, LMICs. In the world of healthcare, it's not just about qualifications and titles. It's about navigating complex systems and overcoming challenges to provide the best care possible. Dr. Bhatti's journey is a testament to the importance of adapting and improving in response to real world circumstances. As a consultant neurosurgeon and endovascular neurosurgeon, Dr. Bhatti's expertise extends to vascular, spine, epidemiology, medical devices, and emergency medicine. His dedication to advancing healthcare services is further demonstrated by his role as a founding chairman and CEO of Neurohealth Care for LMIC. Join us in this enlightening conversation as we delve into Dr. Atta Ul Aleem Bhatti's remarkable career, his insights into the ever-evolving field of neurosurgery, and his mission to improve patient outcomes and health care systems. Get ready to be inspired by his journey and wisdom. Welcome, Dr. Bhatti, to our podcast. Thank you very much for joining us today. Can you tell us where you're joining us from what part of the world?
Thank you, Dr. Melina. I'm happy to be here. Thank you for inviting me and providing me this opportunity to address your audiences. And this is great platform, and I am fan of it. I'm a clinician from rural background. My initial education and training was in Pakistan, and then I did my post graduation in neurointervention from University of Zurich, Switzerland. In my capacity of neurospine and endovascular neurosurgeon, I went back to my home country. And before that, I also had 2 years experience as a young neurosurgeon back 12, 13 years back while I was in Tanzania, and I was working as a consultant neurosurgeon for Aachen Health Services. And that experience landed me to improve my capacity, and that was the first step I took to come to Switzerland to see better systems. And I'm thankful to my mentors who supported me to understand the endovascular neuroanatomy. Initially, I was thinking that vascular part is the most essential for neurosurgeons to execute their operative plans as a safe neurosurgeon or safe practitioners. And for me, neuroanatomy was something vital to all my basic knowledge. and stress to understand neuroanatomy before we do anything for natural history. And for a clinician, I was pretty much clear that we should always try to respect natural history, our limitations. So we should not be quoting the best centers and best professional for their morbidity, mortality problems for our patients. We should get into our own audit, and that's the difficult part for surgeons and neurosurgeons to evaluate themselves and understand their limitations. So, while working in Tanzania, East Africa, I had come across real life challenges. So I had opportunity to travel around in East Africa to understand how other parts of the African countries are doing. So I could see the similar problems, twinning problems. In training years, I used to see many challenges, and that was this extension of those same problems. While working in first world, I could see how predictable neurosurgery is. And by understanding neuroanatomy and neurosurgical techniques, my mentor used to say me the safety comes first, and respecting natural history is the key which we should have in mind while treating the complex disorders. So when I went back to Pakistan, I was working for neurospine and endovascular specialty, and I could see again, even with a better ground of training, you come across a lot of challenges. Like, as a clinician, you can't change the whole system. Technology is innovating fastly. We see artificial intelligence and robotics coming into surgical field. But when we see the ground realities in lower middle income countries, we struggle for basic things. So while operating, you are the captain of the ship, and you are accountable for everything which goes right or wrong. But unfortunately, the things are not in your control. So technology is becoming very difficult. Even the basic one, while you work in this specialty as a private practitioner, and even governments setups has their own chunk of problems. So when we talk about neurological practice, we have to keep certain things in mind. So we always think like a epidemiologist for surveillance incidences of the diseases. We have to focus on preventions. We have to improve the diagnostic part of the neurological problems. And then it comes to acute care and finally rehabilitation. So we jump into the sea of acute care as a neurosurgeon in lower and middle income countries. But our training, our environment doesn't give us support from other angles. So we have missing data or unavailable data. We don't have optimal equipments available. Even if equipments are available, they might not be in order at times, and you get surprises in the mid of your operative procedures. You are in a capacity to benefit many people, but how can you address those problems when you are in a clinic seeing a patient with brain tumor and he asks you, or a family of that patient asks you, how much will it cost for the treatment of glioblastoma multiforme, or a brain tumor which is supposed to be a glioblastoma multiforme? They think that they are in front of somebody who has answers of all this disease and all their questions. So, while working as a clinician in those limitations, you end up getting burned out very easily. On top of that, COVID years made things even difficult for non communicable diseases. So, the data shows that almost 70 to 75% problem list of diseases in lower middle income countries are linked to non communicable diseases. And neuro problems are vital to, or neurovascular problems are vital to those non-communicable problems, which ends up in morbidities and mortalities. Does not only impact patient but also whole family suffers. So the cost of a brain tumor treatment, irrespective of outcome, becomes lifelong impact on family, and unfortunately, most of the time, whole family suffers. And on a bigger scale, whole system suffers, whole society suffers. So that was the motive behind my move to found my own organization. So I was in contact with my colleague, Dr. Bernd Dobler. He's a neuroradiologist, a colleague from Zurich fellowship days. So we kept on brainstorming these ideas, outbursting our own frustrations. And recently we could make this move materialized to found our own organization because, like every doctor, like everybody in health system, problems are very evident, similar across the whole map of lower and middle income countries. But when it comes to solution, we thought we should not become a part of problem. We should become a part of solution. So we decided to move and found this organization. Now we are ready. We have a base in a city and country where the international policy makers are existing. Their influence on the policies, their technology driven companies are working here. Research is one of the most fundamental priority of their education system and health system. They are willing and they are supportive for us to work in this cause. So within few weeks time we could go through all the legal filters to establish ourselves. Now we are looking for host contacts, for alliances, partnerships, and we are basically looking for governments, the health ministries, NGOs with a similar cause. We are also looking for donors and those people who have been through directly or indirectly the sufferings of neurohealth cares, either themselves or witness the misery of people, and they are willing to help the groups. But when we look into solutions, we have to see that many groups, many individuals are working. So why should they support us? That's a question everybody would ask us. Just like in my background, I have shared all the details why I chose this hard way in the mid of my career when I was comfortable working as a neurosurgeon for my family. And if I was selfish, I should have continued that way for another decade or 2 decades. And I would have retired from my career. My mission right from the start was to impact millions in need.
Yes, and can we go a little bit back into your past? Speaking about this mission, what motivated you to become a neurosurgeon in the first place? And I remember you shared with me a story living in the village and the state of healthcare. I think there was a personal story that also motivated you to get into that field. I think it's very relevant to the work that you are doing. Maybe you can share it with our listeners.
Yes, I was very keen to see growth in different systems. Education was something I was witnessing because my parents were in teaching profession. So they came all the way from Kashmir to other corner of the country, and I could see a very broken health system. So why I say broken? Because the basic health system requires a general physician level, family physician level, obstetric, and these categories. So finding a doctor, qualified doctor, who is ready, who is empathetic, who does help you as a human being, not as a customer. was a challenge and is a challenge and will remain a challenge for people living in any area of the world, especially in lower middle income countries. So even if somebody is well trained, well prepared, he has limitations. Many of the doctors, they go into medical field just for the sake of pleasing their parents or following their wish to have their kids as a to see their kids as a doctor. That's a very common scenario in my circle. I think I was a believer that if I go into some field, I would work for humanitarian cause and I will impact in a different way, not in a monotonous way, because I was not happy to see that a neurosurgical or a acute surgical emergencies were not being taken as an emergency. Because when the basic system is not ready to from the trauma, if there is a head injury, right from the pre emergency rescue. Similarly, the stroke is same story. Prevention of risk factors for strokes. So these are very common things: stroke and head injuries and epilepsy. So still, the epilepsy is something people don't admit that they have this disease, and it comes with the education. So education and health goes side by side, and both are unfortunately not picking up in lower and middle income countries because of poverty, maybe misutilization of resources, misutilization of policies, no surveillance or continuation of good things which is done by the government or health authorities or WHO. So the things are still, I could see that the medical system and especially the neurohealth care was very desperate. Those fields needed people to work, people to come in and work as a cause. So I remember one of our neurosurgeon, Professor Majid Sami, is in Hanover. He says, when you understand neurosurgery as a neurosurgeon, probably half of you would not be able to continue practice because you won't be physically fit enough to meet the demands of neurosurgery. It's a long neurosurgical disease routine in training or in profession. Uh, Burnout is very easy. So, as I already mentioned, that many factors are not in the hand of clinicians. So, I decided to get myself well trained in neurosurgery. Not only that, but I also moved to influence policymakers, governments. At least I can raise my own voice to bring in some momentum in the progressiveness of the field. And I am ready to outreach those systems where neurosurgeons are either not present or not willing to continue. Because in many Western universities, many Western neurosurgical groups, they are working for lower middle income countries. But many trained people from lower middle income countries, they don't go back and they don't continue working there. So they eventually, all which is done goes into failure. So when we say that innovative strategies for achieving this transformation of holistic care to lower middle income countries, we should be honest and we should see how to move sensibly, how to spend money on the equipment or resources. So, we as neurohealthcare for LMIC, we want to partner the local groups of neurosurgeons, governments to bring in our expertise and utilize this technology. For example, we can offer online clinics, online supports to professionals, to patients, and for complex problems, we are ready to go provided the authorities support us to selectively treat those cases, to train local human resources, so technicians, nurses, and other. So this all needs a continuity of care. So my international group of neurosurgeons, few from Pan and few from other part of the Europe, they are ready to join hand when we start practically going to those places for providing services.
Maybe you can compare and contrast the neurosurgical care, let's say, in Pakistan and a rural area compared with Switzerland or, Africa. You were also traveling there, Tanzania, yes?
Right. When we see the cross-sectional situation, it's very poor because we don't have enough data available. So those patients who are supposed to go to a neurosurgeon, they never see a neurosurgeon because of non-existing referral system or broken primary healthcare system. So that's one problem. In when I say lower middle income countries, the problems are same everywhere. So when we don't know the problem, the extent of problem, the burden of problem, how can we plan? And even if we plan, there is a very minor part of budget is allocated to health. And most of the time, that health care budget goes to other non-communicable diseases. And usually the emergency care services like neuro health care, when a patient needs immediate, unplanned surgical or management need, they don't have any support from the system. They don't have any insurance based system. When it comes to trauma or stroke, so pre hospital care is missing. Even if people report to a hospital, they are not ready to tackle those emergencies on a priority basis just because of their own limitations. Beds are not available, ICU beds are not available, surgeons and operating rooms are very limited in number. So the cost of technology is making areas more difficult to approach those technological support to come to them in the right time. I remember I started doing neurointervention 10 years back. So I started on a simple monoplanar machine. So maybe nobody is using here in first world. Even that machine, the radiation protective measures were not sufficient. So we often disconnected to each other. The professionals, the private setups, the private were private and government setups. There's no communication. So just like ventilation perfusion mismatch, there is a mismatch of human resource and equipments. You find equipments and human resource in government setup, and people are not willing to go to those centers for one reason or other reason. When it comes to private setup, it's too costly, and maybe lifetime earnings cannot support people to sustain that. So when I started that, in all stakeholders, the communication lapse was enormous. And I remember as a clinician, many times my input was missing in whole planning. So as a clinician, I used to work in clinic or operating room and ventilating out my frustrations. And the policymakers, they used to get input from somebody who never had any exposure to operating room or angiography suit. So how can those people suggest the solution to problems? So if clinicians are not okay, how could they bring in the best for the patients? And when you work in a setup where patient cannot approach in time due to many issues, so the system thinks that the laboratory is in private setups, laboratory is more profitable business than neurosurgery. So why to put their attention into a field which may not be beneficial apparently to system. On the other hand, the government provides all the facilities to government setups, and these problems are not new. They are similar everywhere. So the academician, they not only work for government, they also compete in private setups with the clinicians. They want the professionals like me who are willing to work in government setups. They usually don't get those avenues to support masses. It's not easy to induct into that system. One indicator for health sector is how we utilize time of operating setup. If a government setup has all the machinery, all the equipments, and the clinicians are not available after 2 o'clock or 5 o'clock, that indicator of utility of the space for non-regular clinicians is possible if we really want to help the masses, help the workload. So we have to design some new way to deliver, and it's only public private partnership, nothing else. Neither a public sector alone or a private setup alone can deliver all which is needed. And not only public private partnership, but international organization donors, if they are helping any system, it should not be just unconditional support. It should be a policy of support which should be based on the performance, the change of healthcare. So if we see generally mortality, morbidity index, or common health indicators for improvements, so I'm sure epidemiologists can have a clear view sitting thousands miles away. If they know the mortality, morbidity patterns, they can clearly see what the system would be. But in neurohealthcare, the data is missing. Even you cannot find the incidence, and so the research culture is very necessary. So I'm happy that medical students are more into research areas, so things are improving. It's not that we are static, but and federations and associations, world federations and world professionals are helping them, providing them different floors to publish, to share, to present their findings. So these are the good things which are happening. And I'm sure each step is going to make a difference. But we should not forget these steps are too small and too slow. The population, the neurological problems, they are moving very fast to a pace which we are not ready for. And it's a established fact that till 2030, when I was a medical student, we used to listen the slogan that health for all in 2000. Now we say neuro health for all in 2030. But both dreams are not coming to a reality. But at least we should have some impact on the current situation. So there is every area which we have to work together. So it's not only clinical work, it's a research work, coming up with more fruitful collaborations, some meaningful support to those who are really dedicated. It should not be a support to already existing players who are not bringing in change. So if you keep supporting those people without any accountability as international agencies or policymakers, you cannot achieve a different result. So for a different result, you have to bring in a different strategy. And now is the time to bring that strategy. If we look at 2030 or 2040.
Yeah. And speaking about 2030, 2040, you mentioned that slogan, Neuro Health for All. How do you see this in a reality? Can you describe your ideal vision of the world where neurohealth is for all?
See, every citizen of the world has a right to get a health care, which is a dream. And the problems are obvious. My dream is to see every neuro health patient to at least reach in time to experts and get the best shot of the disease. And the realistic goals should be there with the clinicians. The holistic approach should have empathetic environment. So time is brain, what we say. So if we miss the stroke patient in initial hours, we miss the chances of recovery. If we intervene in a setup which is not ready to deliver the best interventions, we might hurt the natural history. And we do the same thing. And despite investing more funds, we waste that. So if we are ready to deliver that healthcare in a neurological disease, it's not one time treatment management, it's a lifelong support in the form of neurorehabilitation, in the form of epilepsy treatment. So there is a cost the whole system pays. And I think it's a complicated area. And universal health is something which is not easy. And I'm sure anybody could not bring in solution to that. But at least we could improve the situation. We have to focus on the right targets. And clinicians like me who are ready to work, ready to dedicate, should have access to policymakers, should have access to funds and support, and they should get chances to see the groups of people. They should share their problems while they observe their career. And we should not just roam around in the circle. So, sharing, having a clear insight into the bulk of problem, the strategies to reach right target in right time, and having diagnostic treatment and rehabilitation as well as long term plan for patients. That's my dream. And living in the advent of technology, we could sit thousands miles away from the system and still we could contribute. And the technology, so one of the area I'm looking for is how to make sure that we could provide the low cost technology. I can give you an example of neuro navigation systems. So with each year or two, a new neuro navigation system is coming up and the cost is drastically becoming higher. Same is for microscopes. But I could see that the latest microscope or latest neuro navigation system is not going to change the situation if you don't know how to judiciously utilize that resource. And centralization of neuro centers, like a country of 220 million, should have neuro healthcare tertiary setups in each corner within the reach of 100 kilometers. So every 5,000 people should have a neurosurgical exposure to a neurosurgeon. But unfortunately, the World Health Organizations put a standard of 100,000 population versus a neurosurgeon. That's the minimum. But you could see millions of population not getting access to neurosurgical services or neurology services. So we have to tackle this reality as an emergency. So awareness is increasing, but we have to be at a next level than the disease itself or spectrum of diseases itself. And it cannot be possible without supporting the systems, collaborations, funding into right directions, having a low cost solution, individually tailored for the individual system. So you can find a center with all the equipments, but nobody is willing to utilize those.
Yeah, and speaking about that, if we're starting from the very beginning, you mentioned that many people are even not willing to recognize that they have a neurological disorder. What is the reason for that? Are there any stigmas still existing that affect people's willingness to recognize their condition? What is going on? Can you elaborate on that?
Yes, this education system, the social system, education provides people opportunity to understand realities. Unfortunately, health, science, technology, if the masses are deprived of these areas of education, then you could not get the scientific basis of diseases. And yes, stigmas are there in society. So people are shy to accept that they or their loved one is suffering from epilepsy. Parents of young girls in many social levels, they won't share this just because they won't find any match to their daughters. So it's still there. Socially, people are afraid that how could they be acceptable to society. So, like simple improving if disease happens like stroke or epilepsy, providing them help, awareness, providing them opportunity to see other patients, that group treatment, that social interaction of the families and patients. So the system is overwhelmed with patients. System is not prepared to address those areas. If the children who are next generation, if they don't get these facts, the diseases, the scientific basis of diseases, the empathetic part of management. A simple fact is like a civil administrations who plan for civic facilities. If they don't provide paths for a wheelchair, if you provide 1,000 wheelchairs to that area, you won't give any benefit. So the low cost solution helps from the outside world, can help, can provide an opportunity to get a momentum. But the change will not come until and unless people in that society, in that system, in particular population, they are not aware right from their educational system. So syllabus should have these things: the the care of disabilities, the recognition of evolving diseases, emergencies, and the basic drills, how to provide a first aid. So the things are things need improvement in academia. Policymakers, they have no clue, even for tiny resources which they spend on health. The share of neurological diseases is missing. So the policymakers, the lawmakers, they should either represent from us, or we should have access to them. So media, at times they just sensitized newses in countries, but they don't do actively. And if they do, they really do a great service. So that's a part of fight against neurological diseases, that not only the doctors, the neuro doctors, nurses, technicians, healthcare workers, but also society, educators, media, policymakers, they all should be contributing to this cause if we would like to bring in positive change in the life of patient and families. So if a disability is there, how to rehabilitate? We missed that part. So in last 10 years, you could see a lot of groups in lower middle income countries. They are trying to sell mechanical thrombectomies or stroke intervention as a magic solution to stroke disorder. But are we giving same attention to risk factor control? Are we treating diabetes and hypertension? Are we providing the pre-hospital care for stroke? Is the system already providing stroke treatment similar to what it was there in first world before this mechanical thrombectomy? No. The answer is no. But the more number of patients are going through some invasive procedures for stroke based on the media hype that this is the magic solution of all strokes, then you end up making more disabilities, and you are not planned for the to to support those patients and families. So the local guidelines, the local indications are also important. It's not like I can practice something. Rome was not built in a day, single day. So if we want to bring in the tertiary, super tertiary healthcare to a system like a stroke intervention, we have to pay attention to all the phases of diseases, right from the prevention to pre-hospital and emergency and then rehabilitation. Otherwise, we'll will not serve the disease or patients.
Yeah, and I can imagine that probably the neurosurgical cases that you see, let's say, in Pakistan or in Tanzania, often might be more difficult, more complex, more severe that you would see, let's say, in Switzerland, yes, or the United States. And why I'm saying that? Because as you say, people are not educated, they are not aware of any signs, they don't report them, they don't get the first care they may need. So the disease progresses, and when finally the person already gets to the health care, very often it's too late or disease is too complex to handle. Do you see any differences like this in neurosurgical patients, let's say, in Pakistan versus, Switzerland, Europe? And
Yes, I will just generalize this to lower and middle income countries. So there is a lot of improvement in certain areas like infection and CNS infection and neural tube defects. But still, the rural population, basic surveillance during pregnancy is still missing. The infants, neonates, they don't get proper attention. When it was missed during the pregnancy, that neural tube defect was there, which could have been avoided initially. Even after the birth, the basic treatment of neural tube defects could make that individual productive. So one of our target is to outreach those obstetricians, child specialists, and other rural care setups to pick up those. So what I see is still neural tube defect is a major problem in lower middle income countries. It's hardly a frustrating issue because of good diet and folic acid sufficiency uh, to, to, to the first world neurological practice. But we see neural tube defects, we see infective problems and problems related to infections like brain abscesses. We see huge tumors which should have been diagnosed earlier. They either were not diagnosed, or if they diagnosed, they were not treated in time. And there are brain abscesses, there are gliomas, there are metastatic diseases, there are trauma is still a major problem in lower and middle income countries. The traffic rules regulation and same. You can make the system more prepared for discouraging accidents. So the very basic interventions are missing, like a helmet use in a biker or proper signal systems. So proper roads. I remember 1 kilometer patch of a road where I used to see accidents every week. But civic policymakers, uh, if they don't give attention to that causes of accidents, merely providing trauma care won't be the answer to problem. So there are problems which are linked to basic things like trauma care. People are investing on a level one tertiary care center, but they are not ready to invest on basic causes. So if they do this, surely that level one trauma would not be answer to trauma problems. I think there is a radical involvement of professionals from the background of clinicians in the policy making at each and every level. No matter if it's out of the domain of health and hospital, in policy, in statistics. So we have to set a priority. I think each area, the like epilepsy, like trauma, like infection, some of them are preventable. So we should prevent those happening. There are other areas, early diagnosis is going to help. There are other areas where we have to make the experts more trained and rehabilitation. So from the neurohealthcare for LMIC, we are planning to gather all the professionals like-minded to contribute their time when they get a break from their routine to serve those areas in various capacities. So we are looking forward for these sustainable initiatives, and we'd like to have more platforms where we could have alliances, partnerships, and interactions. And major thing is for doing all these activities, we have to find out solutions based on individual needs of groups and individual needs of that specific. We cannot generalize to one size fit for all strategy.
Yes. And Dr. Bhatti, you mentioned technology and technological innovations. How do you think those innovations can help address the problems in the low and middle income countries? For example, now we are aware of neurotechnologies, brain computer interfaces specifically, that can help with the stroke rehabilitation and provide solutions for stroke patients that are cost effective, that do not require a specific time even from trained rehabilitation specialist. Their time is decreased because there is more time for this interaction with the technology. What do you think about those solutions and their implementations? Like, there are even brain computer interface gyms for stroke rehabilitations that are developing now across the world. What is your opinion on that?
Yes, that's an area which we could come up with many solutions. Like for a bionic limb work, for a computer based rehabilitation. Obviously, when you make more units, the cost will go down. So, what we have to figure out is to identify research based prospective results of those new innovative areas and judiciously use those breakthroughs. And one of our aim is to make the industry closer to clinicians. So we would like to have many rehabilitation centers, either in the form of mobile health centers, mobile systems, or static regional centers, where we could share these breakthroughs with the group of professionals who are dealing these things. And simultaneously, media, technology, newspapers, they can address those areas. So in this way, those in need could reach to right place in right time. And the cost issue, yes, that's something which is linked to each and every discussion of improvement. So it's not only cost, it's how we utilize those funds. If we utilize the right amount of funds into right place, I have no reservations that we come to see a better result. The less resources addressing to more people and targeted population.
Thank you so much. And maybe you can remember some example of maybe similar pathology. Yes, it's a brain tumor or epilepsy case or trauma, brain trauma. Two similar cases, but one didn't get as much support as it needed because of the situation, yes, in the rural area, and another similar case, but that had all the care that is needed for handling this type of situation. And you can compare the outcomes of one situation versus another.
I think it's a daily clinical observation. So, if there is a limitation of system to follow up neurological disorders, whether it's a stroke, brain tumor, or any other neurological problem. For example, you see patient with contractures, but had they been given motor recovery support, they would have been utilizing their hands and limbs. But due to contracture, it's not possible to productively utilize the grip which came in 3 6 months down the road. So the missing part was no attention to physical therapy or cost. People were not affording. They remained admitted during the initial treatment, and they went and they never gave a chance for full rehabilitation facilities. So that's a common scenario, and that's disturbing, because when the clinicians, the clinical teams, they are disconnected. So you diagnose the patient, you treat, and you forget. You're not no more involved in the post operative phase. If there comes a physiotherapist, you don't have occupational therapist. If you have both, they are not ready to work as a team. Or if they are ready to work as a team, patient cannot afford to go to them because of lack of support. Now we could see a lot of rehabilitation experts are coming up, but the major difference between the outcome in lower middle income countries versus first world is rehabilitation in the similar case scenario. So the potential of recovery is linked with a holistic care to all the phases. It's not if I operate a brain tumor, there is a cranial nerve palsy and a facial nerve palsy, and we have not, or there is a lower cranial nerve involvement leading to dysphagia. The patient will rebounds with aspiration pneumonia because nobody offered that care process for whatever was necessary, NG or PEG insertion and facial nerve recovery process. So these could be preventable. These are the areas where we can bring a change in very short period of time. Public awareness, teaching, involvement of physicians, connection between various teams involved in the clinical process, and the nursing is something which is vital part of that. So nursing case manager should be a key person to keep a track. This is only possible if people are focusing on their practice. If a neurosurgeon who is or neurologist or is working in 20 places, half of his time of day is on the road, on busy roads. So how could he make sure his availability for those processes? So again, the human resource strength is going to count, and giving attention to every clinician. It's a teamwork eventually. So we have to prepare whole team, every stakeholder.
Yeah, absolutely, absolutely. And as you outlined, there are so many problems. Yeah, starting with education, with the existing stigma, with the access to the primary even care, and then the later stages to technology, to specialists. There are so many different problems, and I'm sure that only one person or several people cannot solve all of that. So what did you choose as your primary focus that you want to address first?
I think our role is expanding. We are not only clinicians. So I'm trying to provide bridge to different specialities, so different stakeholders. So whether it's industry, whether it's rehabilitation experts, or people who really want to work for neuro healthcare and they are not getting chances to join hands with the right group. So our role would be to bridge that gap. So we have to link between the influencer, the policymakers, and the end users. So my plan is to work for public awareness, to bridge the gap between the stakeholders, and to keep myself active as a clinician to provide my expertise for complex, for example, brain tumor surgeries, spine surgeries. And if we could save life, we could save hands, we could save eyes, we could save productivity of life, we could save. I used to see, and it's a very common practice that the countries or systems where neurohealth is not available or not specialized. So governments and funding agencies, they support patients and families to go elsewhere. So there is air rescue, there is whole expenditures. Even if that same patient had diagnostic workup done in native place, that repetition of those same diagnostic workup, treatment, and that costs a lot on a budget of government, and they don't either realize or they don't get a right guidance. It's not third party sitting elsewhere could change the whole practices or scenarios. So we have to involve and engage the local players to bring in that change. So a lot of times, basic neurosurgeon and junior neurosurgeon is working in rural setup. He does not get training. He does not see anybody standing behind him from the administrative side for his own growth. So for his own training. And rather than bringing those healthcare workers in any capacity, whether nurses, technicians, or doctors, or neurosurgeons, or speech pathologists, rather than bringing in them to a training center, why not provide them frequent opportunities for the training? If they want to plan a brain tumor and they have never done a brain tumor, an experienced neurosurgeon can join them until they become more comfortable doing those procedures. So, in continuity of the same, it's operating the pre-hospital, hospital, and in surgical routine, the equipments, whether it's a operating table, high-speed drills, or microscopes, or navigation systems, or robotic systems, or angiography setups, you have to have a good neuro ICU care. So that needs a lot of reinforcement of already trained people. So our aim is either to provide support to existing setups, professionals, or if the region or country or province is lacking those facilities, we could also think to bring in new systems. But condition is that the local policymakers and local stakeholders are ready to start that and they are keen to extend those services, sustain those services. That's the target.
Yeah. Can you provide any advice for new neurocare professionals, neurosurgeons, neuroradiologists, neurologists, people that want to make a difference in the field? What would be your recommendation in terms of improving the access to healthcare for all people in the world?
I think honestly, they should, wherever they are in the career, early, middle, or late, they should sit and reevaluate what change have they brought during their career. Is there a new way to rethink if they had a second chance? Unfortunately, the systems are happy to see the number of surgeries, but it's the clinicians who are going to put a quality bar high for their patients. We cannot just quote a number of morbidity and mortality acceptable. So we should be open to discuss and reevaluate what went wrong. So what change could we bring in to prevent those things? It was a very sad moment for me every time during my career to see professionals at various level of their career used to take the complications very lightly by putting that, yes, this happens. I mean, if a morbidity was reported, it doesn't provide you a cover. That's the difference between excellent systems and professionals, that they do their own audit. And it's there are many complexities are involved, but the process should progress towards positivity. So if a professional is unchecked due to his profile, due to the place where he's working, and his quality is deteriorating, and his profile is covering, then I think it's alarming for whole systems, for whole professionals. So sooner or later, that will hurt our professional integrity. Or at least we should put ourselves in the shoe of our patient and families. So that can become a strongest tool to change ourselves towards progressive positivity.
Thank you very much. What is the best way to learn about your company and connect with you?
Yes, I can be reached through LinkedIn. I can share my emails and my contact numbers. We can also share our account details if somebody is thinking to become a supporter. We are available. We are appointing. We are not big team, so all volunteer work is going on. New members joining us. So our plan is to have 24/7 contact number for people to reach to us as a patient, as a family, for support. And we also welcome supporters, donors, and connections could make a difference as volunteer. Or so that's LinkedIn and other numbers would help them to reach us.
Thank you so much. And as we are nearing the end of our podcast, would you like to share anything with our listeners? Anything you want to say before we end?
I think neurohealthcare and healthcare is a complex area. It's not easy to bring in change. It's a process. At least if we are ready to accept and inspect our shortcomings, if we are eager to help ourselves and systems, and eventually the end users, patients and families. So if you're ready to bring a positive change, then it's the right time to start it in any capacity. Even a small step would not go unnoticed. It will contribute to eventual health care of a particular population. And uh, On top of everything, these patients, these families, they are not mere case reports. They teaches us the real teachings, which we theoretically learn all our life. This is a dynamic process. So the disparities, the uh, gaps, they will remain there. But at least we could challenge the static situation. We could make a difference by decreasing that gap, by providing low cost individual tailored solution. That's my message. Okay.
Yeah, thank you. Yeah, thank you so much, Dr. Bhatti. It was a great pleasure to have you on our podcast. Of course, I wish you all possible success, and I hope that the things will be changing, especially when people like you are taking initiative in their hands. And I'm sure many more people will join you, especially after our conversation. I hope it will happen. So thank you again, and yeah, looking forward to seeing the progress you and your team are making. So thank you again.
Thank you.
Dear Neurocareers podcast listeners, thank you for joining us on this incredible journey into the entrepreneurial world of neuroscience and neurotechnologies. I hope you've been inspired by the stories of those who are turning groundbreaking ideas into impactful realities. If you are looking for more guidance on succeeding in neurocareers, book a free consultation with me, your podcast host, Dr. K, at the Institute of Neuroapproaches. So, what are you waiting for? Let's navigate the path to success in the world of neurocareers and make the impossible possible together.